Hello all, myself Helena Joy, lecturer from SNS College of Allied Health Science from the Department of Radiography and Imaging Technology. I am going to discuss a topic about pediatric imaging. Pediatric imaging is important because children do not all reach a sense of understanding at the same pediatric age. This ability varies from child to child. A successful radiographic studies are dependent on two things. One, the technologist's attitude and approach to a child, and the next, the technical preparation in the room. Child development. In the context of diagnostic imaging, childhood can be divided into 6 main age groups, each of which has different needs and capabilities. Birth to 6 months, infancy is from 6 months to 3 years, early childhood is from 3 years to 6 years, middle childhood is between 6 years to 12 years, early adolescence is between 12 to 15 years, late adolescence is between 15 to 19 years. Anatomical differences between children and adults. Young babies have thin skull vault and vascular markings are not present before the age of 1 year. The nasal bones are not ossified before 3 years of age. Paranasal sinuses are not normally ossified until 6 years of age. The scaphoid bone is not ossified before 6 years of age. Children have faster heart and respiratory rate than adults. More radiosensitive red bone marrow is more widespread in children and is present in almost all bones of a neonate. These anatomical differences should be taken into account when optimizing techniques in pediatric radiography. Approach to a pediatric patient. One should always introduce oneself to a child and parent in a friendly and capable manner. The child's name, age and address should be verified. It is important to speak to the child at their level. A very encouraging, reassuring attitude has to be adopted and an enormous amount of praise should be given for every single act of cooperation. Example, you are the best child at keeping still we have had all day and you are clever. What are the common pediatric imaging? Chest neonatal, chest post-neonatal, skull, sinuses, dental, abdomen, pelvis and hips, spine for scoliosis, leg length assessment, elbow, bone age, hand and knees. Imaging equipment. A new digital age is fast replacing conventional techniques in radiography. It has been shown that there are distinct advantages with dose savings of up to 60% when comparing a 1000 speed computed radiography system with commonly used 400 speed system used in most departments. However, post-processing can mask high-dose technique and careful optimization and regulation of digital equipment are essential. Dose measurement. All radiography equipment, including mobile and fluoroscopy equipment, should have dose area product meters in place. These have shown to provide a sensitive and simple method of monitoring and recording doses in pediatric radiography. They need to be of high specification for children, otherwise the dose readings will not be accurate. This is the dose measurement chart. It has of effective diameter in centimeter, lateral thickness is also in centimeter, average weight of the baby in kilogram, average age by years. Radiation protection. The optimum dose for an X-ray examination should be correspond to the ALARA. ALARA principle is nothing but as low as reasonably achievable. And the next protection is of lead aprons and vest. Wearing of lead apron saves us from the radiation. Wearing of a lead thyroid collar, wearing of lead gloves, safety goggles, and by following these 3 basic protective measures in radiation safety. Time distension shielding. Time distension shielding, it provides us from the radiation and it protects us from the radiation. These are the measurements which we can do to save the technicians from the radiation, and these are the radiation protective device. The first image is the thing which is the lead sheet which has been placed for the gonad to protect the gonad from the radiation, and the next one is the lead apron. It protects the whole body from the radiation. Thank you. That's all.